So good afternoon, everyone, and thank you for being with us for the afternoon session for the first day of the 5th Kuwaiti Neurology Conference. I would like again to thank the people, the speakers, and the participants, and the people behind the scenes, actually, the IT people. There are many people here, probably there are more than 10 people working to make this event to be conducted in a nice way. As you know, wherever you go, anywhere in the world, you will find a technology problem and internet difficulties, but hopefully we deliver the knowledge with our best for different people, general practitioners, neurology resident, seniors, people, consultants, with the best updated knowledge. So we'll start first with the satellite symposium. I'm going to moderate this session. I'll take the question at the end. This is a Lilly conducted symposium regarding galcanezumab with acute, the data and the world evidence data from Italy for the acute and preventive therapy. And then I will take any question regarding the satellite symposium.
Hello everybody, my name is Piero Barbanti. I am the president of the Italian Association for Research on Headaches, and I work at the University and Scientific Institute San Raffaele in Roma. And my topic today is to discuss with you the results of galcanezumab in real life, comparing the data we found in these trials with those of randomized controlled studies. Here you see my disclosures. And the first question I want to address you is, why do we need real-life studies? We need because we have to translate efficacy into effectiveness. We have to test and to confirm the safety and tolerability of a given drug. And at least to me, above all, we have to look for some predictors of the response, but in a population which is real life, which is characterized by multiple comorbidities and very often by multiple prior therapeutic failures. So I want to show you the GARLIC study. GARLIC is an acronym that means galcanezumab in real life in Italy. This is a multi-center study, involved 6 Italian headache centers covering 4 Italian regions. It's a prospective cohort real-life study. We enrolled 81 patients, aged 18-65, and we consider those episodic migraine patients having at least 8 days per month. That means high-frequency episodic migraine patient and chronic migraine. We use galcanezumab with a standard loading dose of 240 milligrams, followed by 120 milligrams each month in the following administration with a subcutaneous injection, obviously. And the trial lasted 12 weeks. Patients were allowed to continue their concomitant prophylaxis if the patient was treated with standard of care. This is the population we studied. As you see, is a typical population which is afferent to a certain tertiary referral center, mostly females, 85%. You see the monthly migraine days, 11 days for episodic, 20 days for chronic migraine patients, a very high number of monthly analgesics, and you see also very high disability as measured by the HIT6 and MIDA scores. But please, I want to focus your attention on the last row. 70% of the patients we treated with galcanezumab in the GARLIC study had failed at least 4 prior therapeutic treatments.
Professor Barbanti, the clinical characteristics of the patients included in the GARLIT were very similar to those of the population that was involved in the clinical trials with galcanezumab. What can you tell us about the results in the GARLIT study in respect to what we observed in the clinical trials?
Let's now have a look on the similarities and differences between the GARLIT study and the RCTs EVOLVE 1 and 2, which were performed on patients suffering from episodic migraine, REGAIN, chronic migraine, and CONQUER, both episodic and chronic, but with 2 to 4 prior therapeutic failures. Obviously, the sample in our study was much less, 81 patients, but the primary endpoint was similar, was the same. That means the change in the monthly migraine or headache days at the end of 3 months in this case. And here you see our results, which are very interesting, which are also, let's say, at least in line with what described in the RCTs trials. You see a change, a reduction by 8.5 migraine days in the episodic migraine patient, and by 11.5 in chronic migraine. This also obviously implies a reduction in monthly analgesic intake. And please note also the reduction in pain intensity. This is a feature, an aspect that we do not very often capture in the trials, but is very meaningful actually for the patient and also for us. But we have to put probably more attention on this aspect. I will explain better this point later on. And as you see, we found also a substantial reduction in HIT6 and MIDAS. We found a statistically significance for all these items, but the patient with chronic migraine who showed a reduction in MIDAS score did not reach the statistical significance. I will explain again this point in the next slide. Here we see the results in terms of reduction in monthly migraine days compared to baseline in the GARLIT real-life studies compared to the RCTs trials. And as you see in episodic migraine with high frequency, at least 8 migraine days per month, this was the population of episodic migraine patients we considered, we found a reduction which was much higher than that reported in the prior trials, because we found reduction by 8.5 days at 3 months compared to roughly 4.5 in the EVOLVE and 2.9 in the CONQUER trial. The same trend we found in patients affected by chronic migraine, because in the GARLIT study, we found a reduction by 11.5 days at month 3, compared to a reduction of 4.8 in the REGAIN and 6 in the CONQUER trials. So very encouraging data in real life. So we have to acknowledge that we are comparing data from real life studies to data from randomized control studies. And this is not scientifically correct, but gives us an idea of what does it really happen in our patients compared to what the papers have told us in the randomized control trials. So what is really probably more meaningful is to express the proportion of patients who respond to a given treatment, because it's even more intuitive than the reduction in monthly migraine days. And here you see the proportion of 50% and 75% responders in the GARLIT real-life study. On your left-hand side, you see the result in the episodic migraine patient, and on your right-hand side, the response in the chronic migraine patient. And the results are really very similar, because roughly 75–76% of both patients, episodic and migraine patient, show indeed a reduction by at least 50% of their monthly migraine days at the end of the 3rd month. And as you see, approximately 32%, that means 1 out of 3, which is really a very huge proportion, is able to say, well, I have my migraine days reduced by at least 75%. So these are exciting and encouraging data coming from our real-life investigation. So we have, once again, to be reminded that it's not so scientifically precise, correct, to compare real-life data with data from randomized control studies, but it's it's interesting to also to stimulate your insights and to stimulate your discussion. You see the change in MIDA score in episodic migraine patient in the Garlic study with the red bar, and the magnitude of the reduction, 39.5, is really much bigger than the reduction shown by episodic migraine patient in both the EVOLVE studies and in the CONQUER studies. This is a very interesting finding. But this is a finding that we have probably also to comment, because even though our chronic migraine patient did show a meaningful reduction in monthly migraine days, did show a very high proportion of patients showing a 50% or 75% response rate, actually the reduction in the global disability measured by MIDA score was not significant, as happened in the REGAIN and in the CONQUER study.
Professor Barbanti, we have seen that the results in the MIDAS are quite different between the episodic population and the chronic population in the Garlit. Could you give us your explanation why we observe this difference?
Well, how to explain the fact that the reduction of MIDA score was not statistically significant in chronic migraine patients? Well, we know that the MIDAS score captures some features related to the way the patient lives in the house, with friends, work, and school. And what we know for sure is that the Garlit population is really a very representative population of patients offering to a headache center with complex comorbidities, very often with affective disorders, anxiety, depression, fibromyalgia. And to me, the more reliable explanation is that probably 3 months is a time interval, is a too short time interval to manifest all the improvement in their lives, and so to definitely break the vicious cycle: pain, depression, anxiety, stress, again pain. So I guess that a longer-term analysis of Garlit result at 6 months or later will probably show a significant reduction also in the MIDA score.
Thank you very much for showing us the results with regard to the efficacy. Can you tell us something more about the tolerability in your study?
When a major point of galcanezumab is tolerability and safety, we can confirm this aspect in our real-life study, because patients showed minor side effects, which were very rare. As you see, less than 10% refer at least one adverse event in 1 month, 7% in at least 2 months, and only 2.4 referred an adverse event in at least 3 months of therapy. What do we know about the tolerability of galcanezumab, using also data coming from post-marketing reports? We know that the most common events, which account for at most 10–11%, are local injection site reaction, pain on erythema, and so on, but very uncommon, even though we have to call them common by strictly speaking, are constipation, 1–1.5%, pruritus or cutaneous rash, or vertigo and dizziness, less than 1.5%. uncommon urticaria, 0.3, 0.1, and anecdotal, extremely rare anaphylaxis and angioedema.
2020 was very much impacted by the pandemic. Have you evaluated if the lockdown had any influence on migraine patients?
We know that migraine attacks are the results of the interaction of our biology with the environment. And we know that stress is by large the most common trigger factor for migraine. That's why we wanted to analyze what was the response to galcanezumab and also erenumab in Italian patients during the lockdown, during the said 2020. So we consider 147 patients which were treated with erenumab or galcanezumab in 2 real-life studies called GARLIT, as I've already mentioned several times, and early studies. And the aim of our study was to look for the consequences of the lockdown and probably the consequences of all the limitation to our freedom and also all the stressful events we were exposed to in terms of reduction in monthly migraine days, monthly analgesic intake, heat-seeks, and so on. And what was really surprising is that despite these huge stressful impacts, all these events, negative events, we can witness a significant reduction in monthly migraine days also during the months of lockdown in this population, I repeat it once again, which was being treated with erenumab or galcanezumab.
Thank you very much for sharing with us the results in some of the outcomes in both the GARLIT and the clinical trials. I wanted to ask you, are there any other outcomes that are really relevant for you when you assess the effectiveness of a treatment, and how are the results of galcanezumab on these outcomes in the clinical trials?
There are some other endpoints which have been addressed by post-hoc analysis. For example, the speed of action and the persistency of the effect of galcanezumab. As you see here on your left-hand side, we have seen that the differences in monthly migraine days in patients in the CONQUER studies treated with the galcanezumab compared to placebo was already detectable at the first month. But what did it happen in terms of weeks? And this point is now explained in the graphic on your right-hand side, where you see that at the first week, after the first week of treatment, the number of weekly migraine days was significantly less in patients treated with galcanezumab compared to placebo. And this holds true also at week 2, 3, and 4. So a meaningful reduction in weekly migraine days in the CONQUER trial. So what about the persistency of the effect? What about the sustained effect? Here you see a very interesting sub-analysis in the EVOLVE trial and in the REGAIN trial. EVOLVE trial refers to episodic migraine patients, REGAIN to chronic migraine. And indeed, what I want to emphasize is the fact that we did not find only a meaningful reduction in monthly migraine days, but if you see in terms of weeks, the difference with placebo was maintained every week at the same level of significance. What does it mean? We did not find any end of dose effect. So the effect was sustained over weeks and over months, both in episodic migraine and in chronic migraine. But what about the quality of the outcomes? Patients often refers that they improved not only in terms of migraine frequency, but also in terms of ACTAC parameter duration, severity, and so on. And this is a very interesting endpoint I want to share with you, is the total pain burden. What is the total pain burden? Total pain burden is the severity weighted duration. So is when you multiply migraine hours per migraine severity. Why is this endpoint, at least to me, needed? Because you see here this lady who has 6 migraine days per month. And she is not as disabled as this other woman who has 6 migraine days per month, but who has much longer migraine attacks and much severe, that is, she has a much higher total pain burden. So to sum up, the total pain burden tells us something more than the crude analysis of monthly migraine day. Now let's see this sub-analysis in a patient with episodic migraine in the EVOLVE 1 and 2 patient. And you see that the reduction in total pain burden was significant overall months 1 and 6 in this patient. And on the right-hand side, you see that this difference emerged at month 1 and was sustained over 6 months in patients with episodic migraine. The same applies to chronic migraine patients, because you see that the total pain burden was reduced when considering the overall period months 1 to 3, and also you see here that the reduction was detectable already at the month 1 and again sustained over months 2 and 3. So this means that the impact of the attack is reduced, and it has been calculated for both episodic migraine and chronic migraine, a reduction due to treatment with the alcanezumab of around 40 milligrams in terms of attack duration. So alcanezumab did not only provide a reduction in monthly migraine days, but in a shorter duration calculated in 40 minutes for each attack. So we are handling a molecule, galcanezumab, which provided data on migraine days reduction in migraine disability, very rapid speed of action, and sustained efficacy. How does this translate in daily life? So the improvement in presenteeism, in overall work impairment and activity impairment with alcanezumab versus placebo was significant for presenteeism, overall work and activity impairment, was not significant for absenteeism. There is something that we do not very often investigate, which is interictal disability. What does interictal disability mean? This interictal disability refers to all those symptoms, residual migraine symptoms, or not pain symptoms, for example, anxiety, avoidance, cephalalgia, which can definitely worsen the quality of life of the patient, and which accounts for the fact that really the patient, the life of the migraine patient is not fully lived as required. So it's interesting to analyze the reduction in the MIBS score. MIBS is a acronym indicating the scale to validate a scale to measure migraine interictal disability. And as you see, once again, in the CONQUER migraine population, a statistically significant reduction in interictal disability at, already at month 1 and at month 2 and 3. And as you see, the statistical significance increases over time from month 1 to month 2 and 3. What can we say at the end of this analysis? That in episodic migraine patient, at month 3, 1 patient out of 3 had no longer interictal disability. And what about patient with chronic migraine? Well, in the patient with chronic migraine at following 3 months of treatment, we found a reduction by 30% approximately in those having a severe interictal burden. So very clinical, interesting data. Nice recommendation. Galcanezumab is recommended for patients suffering from episodic migraine with at least 4 migraine days per month, and in patients with chronic migraine who had failed at least 3 prior therapeutic treatments. And patient can prosecute the treatment when episodic if they demonstrate a reduction by at least 50% at -3 in monthly migraine days, and by at least 30% of the migraine days if affected by chronic migraine. So galcanezumab, interesting, is the first monoclonal antibodies recommended by NICE for both episodic and chronic migraine. That's because galcanezumab provided not only data regarding the, let's say, usual efficacy endpoints, monthly headache days, disability, ictal-related disability, but also interictal disability. When a drug is effective, when a drug is safe, when a drug is well tolerated, usually has no problems in terms of treatment adherence. And this was precisely happened to galcanezumab as results from the RCT trials, because in episodic migraine, 80–88% of patients were adherent to the treatment up to 6 months, and 95% of patients when considering the trial performed in chronic migraine. The proportion of patients discontinuing due to treatment emergent adverse events which were related to the drug were less than 2.5%. Less than 0.5% the proportion of patients discontinuing galcanezumab treatment due to the problems, local problems of the injection, pain, erythema, and so on. And roughly 80% of patients referred to have had less adverse events that compared to the past, to the prior preventive treatment, the standard of care. So I want to address now this question. Do you think that total pain burden can be a more comprehensive measure of the efficacy of a preventive treatment than the reduction in monthly migraine days? What's your is impacting also the So I want to share with you some other clinical aspects, because I think that we as clinicians have the privilege to identify some subtle clinical markers. I guess that clinical markers are obviously more easily obtainable, but maybe also sometimes more precise than biomarkers. Please, let's disentangle the migraine spectrum, analyzing more subtle aspects. For example, pain site. For example, the presence of allodynia. Do you know why? Because after all, CGRP is released in the periphery, so of the trigeminal nerve, and so those patients have unilateral pain. That means a pain which is tracing the distribution of the trigeminal nerve, could probably have more CGRP released at that level. But we know also that CGRP is released proximally into the trigeminal caudal nucleus, so it is also responsible, among the others, for the development of allodynia. And so probably also allodynic patient could better respond. Let's see, for example, the presence of dopaminergic symptoms. We know that 30–35% of migraine patients have vomiting and have yawning, which are symptoms related to dopaminergic activation. And again, please consider if the presence of psychiatric comorbidities or the basal monthly migraine days may be considered predictor of the response. And also, it's up to you, it's up to me, it's up to us. Consider if there is a level of prior therapeutic failures, which identify the sort of cutoff, which identifies those with poor chances of responding to galcanezumab. I am now approaching to the end of my presentation, and I want to show you this quite provocative slide, as you see, because it seems that all the trigeminal targeted treatments work in at most 60% of patients. Triptans, gepants, monoclonal antibodies, and so on. This is not a low proportion, because we know that this kind of proportion are indeed very high in pain treatment, in headache treatment. And I want to suggest you to parallel this proportion with that of patients with unilateral pain. Kellman calculated the frequency of migraine patients with unilateral pain in 66%. So it's a suggestion to see in our daily activity is, for example, patients with strictly unilateral or alternating unilateral pain do respond better to galcanezumab. So I want to conclude with some further suggestion. Some other homeworks we have to do. What about, for example, concomitant prophylaxis? Should we stop suddenly? Should we continue? When should we stop, for example? The second question is, even though galcanezumab did demonstrate a very rapid action, do we also have some patients who respond late? That is, are there late responders? Please, we have to identify them. How should, ideally, from ideal point of view, last treatment with galcanezumab? And how should we discontinue it? Because after all, we are not allowed to do a down titration. And lastly, how long should we wait following a treatment cycle with galcanezumab before starting a new one? I want to thank you for your attention with all these inputs, and I thank you once again. Arrivederci.